Prevalence of neuromusculoskeletal pain and dysfunction in open-heart surgical patients preoperatively and at 6 and 12 weeks postoperatively, a prospective longitudinal observation study. 12 to 64% of patients develop new neuromusculoskeletal pain after open-heart surgery, with 11 to 55% of patients developing chronic or persistent pain. Causes of pain include sternal retraction, patient positioning during surgery, and ischemic changes post-internal mammary artery graft. The presence of persistent pain has been associated with severity of comorbidities, younger age, female gender, lower education level, re-sternotomy, preoperative persistent pain, and preoperative high levels of anxiety. However, the prevalence, intensity, and region of pain, pre-op and early post-op, and the time to resolution of these factors are not well defined. We conducted a study over 3 time points to characterise the prevalence of neuromusculoskeletal pain, regional pain, shoulder disability, and sternal clicking. We also looked at the degree of pain and shoulder disability and any factors associated with the development of these measures. Following ethical approval, consecutive patients were invited to participate in the study over a 10-month period. Patients were included if booked for cardiac surgery via sternotomy and excluded if they did not understand English, had a history of cerebral vascular accident with upper limb dysfunction, or developed complications preventing participation in usual post-op physiotherapy. Following informed written consent, the pre-op survey was undertaken. Usual medical, nursing and physiotherapy cares were provided, including early extubation, education, walking, sitting out of bed, and upper and lower limb and trunk exercises starting day 1 post-op. Reply paid postal surveys were mailed at week 6 and week 12 post-op, with telephone follow-up as required. Open and closed survey questions included numerical rating of pain scales for body regions, the shoulder disability score, and questions regarding exercise compliance and sternal clicking. The numerical pain and shoulder disability scores were strongly skewed due to many 0 scores, indicating no pain or disability. Therefore, while the graphs report mean values, statistical analysis was based upon non-parametric tests of the medians. Subjects completing and those not completing all surveys were not statistically different, and therefore the case deletion method was used to address any missing data. Post hoc power calculations indicated our study was powered to 0.88 with an alpha of 0.05. 98 of 114 patients met criteria. Survey return rates were 100, 88 and 82% at the 3 time points. 78% of subjects had complete datasets. Preoperatively, 68% of subjects reported previous neuromusculoskeletal conditions or injuries. Total pain scores, that is the sum of regional pain scores and shoulder disability scores, were minimal in nature, most returning to preoperative levels by week 12. At week 12, rib cage pain intensity alone was significantly greater than preoperative levels. Prevalence at the 3 time points was 64, 88 and 67% for neuromusculoskeletal pain, and 38, 63 and 42% for shoulder disability. Pain commonly occurred in the low back and neck preoperatively, and in the front of chest, neck, rib cage, upper back and left shoulder at week 6. Subjects reporting no pain preoperatively had a significant change in total pain score both pre-op to week 6 and pre-op to week 12, while subjects reporting pain preoperatively had no significant change in total pain score for these time periods. Prevalence of sternal clicking was 11% at week 6 and 7% at week 12. We found no significant difference between recipients of internal mammary artery grafts and recipients of other grafts. In conclusion, neuromusculoskeletal pain and shoulder disability were common prior to open heart surgery, and the prevalence increased at week 6 post-op. However, at all assessment points, the degree of pain and shoulder disability was minimal, and pain and disability scores at week 12 were similar to pre-op levels in our cohort, who undertook usual post-op walking, upper limb and trunk exercise. Only rib cage pain intensity remained greater than pre-op levels at week 12. Pre-op shoulder disability score was positively correlated to post-op length of stay. Women had a higher shoulder disability score than men at week 6 and week 12, and week 12 shoulder disability score was negatively correlated with height. While surgical risk score was positively correlated with pre-op total pain score and shoulder disability score, it was negatively correlated with change in these measures pre-op to week 12.